Hello, everyone. A very good morning. And now, finally, INI-CET is over. You must all be very relaxed, but I am sure you need to, but you are not. It's probably because of the hype which has been created because of the questions coming in INI-CET and this and that. But I must tell you, you need to relax yourself. INI-CET, all these Indian exams are a hard nut to crack. So it's absolutely all right. You've done well. You just need to relax, take a break, and then continue further. So, whatever has happened, has happened. But the important thing here is to learn from our mistakes, to rectify them. And if we do not get what we wanted, when we sit the next time, we make sure we do not make such mistakes. So, with that aim, I am discussing this recall, which is purely based on the recall of the questions by my students. I know because of the panic created by some of the questions in other subjects as well. There might be some variations in the presentations, but yes, as far as what is the best that we could get, we'll discuss that. So just sit back, relax, we'll discuss, and then in the end, I will give you my version of how INI-CET was from ophthalmic point of view. So let's get started. So this was the so-called panic question. Well, it said identify the structure marked here. But before I discuss this question, I would like to bring into notice that please remember what I always say. Exams are much more than just knowledge. You're right, it is knowledge, it is your luck, uh, but it is a lot of common sense. And this question has proved it. There was a mistake or there was an error which was on the other side of the table, that there were some markings on the image that was shown here, but you were on a side who could have benefited out of it. Now let's see how. So the question said identify the marked structure, and the structure marked here was this, right? The structure marked here was this. All right, so if I did not know anything about this question, but I was happy that this question was discussed in the classes, in these sessions. Yes, there was always something in my mind that is it really worth teaching this part of anatomy, because it is something which is on an advanced edge, on a higher edge. But this question coming in this exam has proved, yes, my wit was actually right. So anyways, even if we did not know, let's see, we knew this is not lens capsule here. The lens capsule has nothing to do here. So this was actually out. So this was gone. It said anterior hyaloid. So whenever we talk of anterior hyaloid, what is anterior hyaloid? Anterior part of the vitreous. Hyaloid is vitreous. So basically, when it said anterior hyaloid, you could have written here vitreous. And do you think this is anterior vitreous here in front of the ciliary body? No. So this was also gone. So now we are left with two. And the rule of two is that whenever you are confused in two options, you are always to attempt it, because you have the 50% chance of getting it right. So this was a question which was to be attempted. 50%, and even if it was a blind guess, you should have done it, because now you were guessing between two options. Higher probability of answering it correct, okay? Or maybe 50% probability of answering it correct. So now let's see. It says canal of Petit and canal of Hanover. Now, before I answer these two, let's discuss what are we talking of. So basically, what is all this being talked about? All this is being talked about is zonules, right? So what are zonules? We know these are suspensory ligaments which hold the lens together, connecting the ciliary body and the equator of the lens, and some part anterior and posterior to the equator, right? So basically, when we talk of the zonules come like this, come here, and then they attach at the equator, anterior and posterior to the equator. Okay, so first let's mark which is the anterior side. You know the posterior side is more convex. You all know that the posterior side is more convex. So this is posterior and this is anterior, the first step. The second step is now the zonules are coming from here, lining the pars plana. So let's name the structures that we know. So this is pars plana. These ciliary processes are pars plicata, right? So basically the part which is lining the pars plana is called as, what is it called? It is called as pars orbicularis. This is called as pars orbicularis. Then the zonules come like this and they come and line the pars plicata. So this part which lines the pars plicata is called as, this part is called as zonular plexus. Then while coming here, it takes a bend. It takes a bend. So this bend here is called as zonular fork, right? And then it divides into 1, 2, and 3, and these are called as zonular limbs, which are anterior, equatorial, and posterior. So before we answer, I know this was a so hyped question. That is why I'm discussing it here, right? So there's an anterior, equatorial, and posterior. So this is anterior, equatorial, and posterior, right? So now you understand the parts of zonules. So now what is happening is this area which is present between the anterior and the posterior zonular limb, the part in yellow is called as Canal of Hanover. Is that clear? Is that okay? This part in yellow, can you give me a thumbs up if things are understanding? You are able to understand. I'm discussing this in detail, though this is just a session for recall, but I'm discussing it here because knowledge grasping there is never late for grasping knowledge. So from wherever you can learn and remember these things, you have to, so that you do not make a mistake again. So is it audible? Is it visible? Is it audible? Is it clear? There's no audio visual glitch. Please, can somebody give me a thumbs up? Right? So this is Canal of Hanover. Now the question was, what is Canal of Petit? Now if I mark this part here in red, here this is the posterior part, so this is vitreous. Or this is anterior hyaloid, right? So there are these zonules which are present here, also lining the anterior hyaloid to ciliary body, right? So these are called as, this red structure is called as, here if you want to see, this is the anterior hyaloid of the vitreous, and this is the hyaloid zonule which I have just drawn, which is the zonule connecting the ciliary body to the anterior vitreous. So the canal of Petit is, I will label it in black, this part in black, which is labeled, this is canal of Petit. That is the one which is present between the posterior zonular limb and the hyaloid zonule. Is that clear? Is that okay? Right? So this, just to label it again, so this is the hyaloid zonule and this is the post-equatorial zonule. So this area in between is the canal of Petit, and the area between the two, anterior and the posterior zonular limb is called as canal of Hanover. And this is the canal of Pettit, the one between the post-equatorial zonule and the hyaloid zonules. And this is the hyaloid zonule. Okay, and canal of Hanover is the one which is present between the pre and the post-equatorial zonules. So does that make sense now? So what was the, coming back to the question, so what was the answer here? So identify the structures. We had already, taken out two. It was Egger's line, or it was anterior hyaloid, or whatever it was. We have taken out two. So the answer was between canal of Pettit and canal of Hanover, and now we know the answer is canal of Pettit. So now you know all the parts of the zonules. So you should remember the part of the zonules, the canal of Pettit, canal of Hanover, and what is hyaloid zonule. Okay, so this was the question which had created a lot of hype, and thank you for making this question a jackpot, for teaching me, making me realize what I was doing was not over and above layering them with knowledge. Always used to feel it is, causing a lot of stress in the students, layering them with such knowledge, but this question has basically done justice to me. Thank you. So are we clear with it? Are we okay with it now? So this is canal of Pettit and canal of Hanover. Next, we come to what is the following is the example of direct gonioscopy. So basically, when you talk of direct gonioscope, it was something which was very, very direct question. We know what is direct and we know what is indirect gonioscope. So just to quickly revise, if you want to revise here, let's see. So when we talk of, okay, I'll do it like this. So when we talk of direct and indirect gonioscopes, we need to know when we talk of gonioscopy, let's quickly revise. We know there is a direct gonioscope and there are indirect gonioscopes, right? So these are called as goniolens and these are called as gonioprism, right? Why prism? Because they have mirrors. And since they have mirrors, so they give you a mirror image of the opposite angle, right? So now you don't have to stress. I don't need to stress more on this. There is a mirror image. One thing, it is inverted. It is literally inverted of the opposite angle, right? You are seeing the opposite angle, but that image is also inverted. So when we talk of the direct gonioscopes, what is the mnemonic to remember the lenses? So the mnemonic to remember the direct gonio lenses is, there is ALS, BLS systems that we learn. So BLS to right kidney. So this is the mnemonic to remember the direct gonioscopes. So let's see, what are we talking about? By B, I mean Barkan, Leyden, B, L, S is Swan Jacob, T is Thorpe lenses, R is Richardson Schaeffer, K is Coepes lens. Is that okay? So it was easy. So this was a direct question asking about gonio lenses, and to remember, they give you an erect image. They give you an erect image and you visualize both the angles simultaneously. Right? So this was the BLS to right kidney. So if we see BLS to right kidney, what do we have? Zeiss, Goldman, no. So the correct answer here was C and D, which is Coepes and Richardson Schaeffer lenses. So the direct gonioscopic, direct gonio lenses are Coepes and Richardson, and the indirect or the gonio prisms are, they are Goldman. Now you all know Sussman, Posner, Thorpe 4 mirror, and Zeiss lenses. Right? So it was easy. It was a direct question. Now there will be no confusion. So indirect are called gonioprisms because they have mirrors. Again, this was discussed so many times. It was a direct question, no scope of error. If you do not remember such direct questions, then there is a problem with us if we do not remember, not with the question, right? So this was a direct one. So this was direct +1. There was no question of not knowing this, right? So here I will again write here. It is BLS to right kidney. Done? Okay. So we move on to the next one now. So that was simple. Now there was another blaster. Sequence of staining in dry eye. So this was a question which again has run, into everybody's spine. What is happening? What is going wrong? What is there? See, in such questions, again, I would tell you, knowledge is one, common sense is two. Suppose now this question has two meanings. It says sequence of staining per se, sequence of staining in dry eye. So it can be either like this, that how do you stain? What is the sequence of stain in dry eye? The other thing could be what it meant was the sequence of staining in dry eye, but it is asking of the sequence of dry eye and its staining patterns. Right? So the confusion started happening. What do we mean by the question? What does the question mean? So now you have two kind of questions, but forgetting everything, let's see what are we trying to do. So I don't know what was the fourth option. I still do not know. So I'm dealing with the three options that we had. So we had fluorescein dye, Lesamine green, and rose bengal. If I do not know anything, let's quickly first revise about the dyes. So when I talk of fluorescein dye, I will use an orange color and I will talk of fluorescein dye. So when I'm talking of fluorescein dye, what is the mnemonic that we remember? OBG. So we know it is an orange colored dye which is irradiated by blue color of the lower wavelength and emits green color. Itna sabko pata hai? Everybody knows till here? It was simple. Okay. Now you need to know what does it stain. It stains both cornea and conjunctiva. One thing. The other thing that you have to remember that it also stains the areas of epithelial breakdown, which is happening in the cornea. Right? Why? Because this adheres to the basement membrane. So it stains areas of epithelial breakdown. Simple. So now that means both the components of sequences of dry eye, whether being conjunctival or being corneal, are being covered by fluorescein. Right? So this means this cornea bhi cover ho raha hai conjunctiva. So even if conjunctival xerosis comes or corneal xerosis comes, fluorescein is going to cover both of these. One thing. Second thing, what is the use of fluorescein in dry eye? Let's see. So use of fluorescein in dry eye is for standardized grading. Here lies the answer. Grading of corneal and conjunctival staining. Again, it covers both. Also used in TBUT and to measure the tear meniscus. So, anyways, since it is covering the sequence of dry eye also and sequence of staining also. So, the first option and the most commonly used stain, and this is also the most commonly used vital stain. So, seeing every possible manner what the question meant, the first option had to be 1. So let's see. 1 is here and 1 is here. So that means these two are out of the line. And since now you're left with 2 questions, we had to answer this question. So now what we have to decide what happens next. Now next, when we talk of other dye which says 2, which says lissamine green. Now when we talk of lissamine green, and the other is rose bengal. So rose bengal is actually a derivative of fluorescein. We all know that. Important thing is it delineates or it stains what? Dead, devitalized epithelial cells plus mucus, right? But this was an older concept. The newer concept says it stains anything. It stains any ocular surface which is not protected by the tear film, right? So the newer concept says it stains ocular surface not stained by tear film. So again, this says it is going in the favor of dry eye. It is used in the workup of dry eye. But the problem here is side effects, right? It is something which is very toxic. It is surface cytotoxic. It is surface irritant. And it causes ocular toxicity, right? So rose bengal takes a back seat. What is lissamine? Lissamine is basically a food additive dye, right? It is a food additive dye which again stains devitalized epithelial cells, which is similar to rose bengal, plus mucus, plus it stains disrupted intercellular junction areas, right? So till now we are still confused between lissamine and rose bengal, but remember this gives you a prolonged staining and is not toxic as much as this. So the second option would be lissamine green, and the third option would be rose bengal. So we have 1, 2, 3, which was the correct option. But now, are we still sure what are we discussing? So I have the jewel here. I have the gold or the diamond here. So this question was a direct take from this paper which was published in 2022, which talks about ocular surface staining, current concepts and techniques. And it clearly says, first is fluorescein. Fluorescein staining. So this paper talks about the suggested order of dye application for ocular surface assessment. So I told you this is the answer to all the confusion. So the first was fluorescein staining to first assess the tear film breakup time and followed by assessment of the corneal staining and also the conjunctiva. The second was lissamine green staining, and third was the rose bengal staining if required for conjunctival surface assessment, because lissamine is actually assessing the conjunctiva. right? So this question was a direct take from this paper. And if you want to read this paper in detail, I have tried to sum up everything about the dye in these slides. But if you want to read them in detail, I will put the entire paper, the entire literature of this paper on my Telegram group, which is by the name of Dr. Bhumika I, and also will put this slide with this entire presentation with annotations on my Telegram group. So if you want either of these, the presentation or this article, you can directly take it from that group. Okay, so this is all. So there were these two questions which were creating all the hype around INI-CET. So I'm telling you, everything is there, but the only problem is applying common sense. Even if we did not know, still I showed it in the end because I wanted you to realize what common sense can do, even if there is some glitch with the knowledge part somewhere, right? So it was simple. So fluorescein dye, which is most commonly used, which was covering both the things, conjunctiva and cornea. Then you have lissamine green, which is covering the conjunctival part but is less toxic. And then is the rose Bengal dye. All right. So is that okay? All right. So then we go to the next one. Now it says true about glaucoma is, and I have a big thing shown here, which is this. So what do you mean by this? This was a googly question. Why am I saying this was a googly question? Now let's see what it is talking about. Now this is talking about the earliest and the specific changes, isopter contraction and bearing of the blind spot. Is that right? Let's see. It says earliest, I do agree, but it is not the specific change. The specific change, we know the visual field defect that comes. The most specific, earliest visual field defect, which is specific to glaucoma, is the paracentral scotoma, which is coming in the germs area. So this was a wrong choice. That is quite understandable. The other thing says in static perimetry, the intensity of stimulus is kept constant and the stimulus is moving. Verse says static and it says the stimulus is moving. It doesn't work. We all know in static perimetry, the stimulus is not moving. The stimulus is constant, but it is the intensity which is actually varying. So this is also wrong, right? Next it says in kinetic perimetry, kinetic perimetry is the best diagnostic modality for monitoring the field changes in glaucoma. Is it? No, we have learned so many times. It is not kinetic perimetry. What is the correct answer? The correct answer is, it is static perimetry. That also makes sense. So this is also wrong. Visual field defect is associated with optic nerve head changes. Now you would say, ma'am, D is correct. But I would like to say, hold on. This was a repeat question from the PYQs. I think I'm covering this image, but if you see, this was a PYQ, which was asked previously. So what was the older question? Older question said true about POAG is on gonioscopy. We have discussed it so many times in the past, but I'm still repeating. Let's see. It says on gonioscopy, blockage is seen at the level of the trabecular meshwork. No, this is wrong, because if there is a blockage, then it is not POAG, it is angle closure glaucoma, or what is called as angle closure disease. Then it says family members are at a 1% higher risk. This is also wrong, because we know it is there, it is higher than 1%. So what Baltimore says 3.7 fold, and what the Indian textbook says 10% in the siblings and 4% in the offsprings. So this is also wrong. IOP always rises on dilation. No, because what we are talking about is of POAG. So this is also wrong. So because this happens in angle closure, it says visual field effects can be seen with normal CDR. So this was a previous year question. And now says visual field defect is associated with optic nerve head changes. There's just change in the language. Here also, this was not. This was the correct option. Visual field effects can be seen with the normal CDR. We have discussed this. So that means visual field defect associated with optic nerve head changes is also a wrong choice, because visual field defects may be present in glaucoma even without optic nerve head changes, though they may not be very significant. Hence, I say this was a googly question and it was not to be attempted. So let's see. We have discussed in the previous year questions about this. How can visual field defects occur without the optic nerve head changes? Is my answer here. We have learned so many times that we do get these wedge defects. So what are these wedge defects? These are the RNFL wedge defects that we get to see in the red free illumination, and they are seen in early changes in glaucoma. And if you do not remember this question, it is our error, it is our problem, because we were not thorough with our PYQs. If I could catch it, you should have. Right? So this was again a previous year question. So this was early changes on glaucoma, which have not started affecting the optic nerve head, but will be seen in the field changes. Why? Because nowadays we are so well progressed with even the detection of smaller changes during the fields with the better technology. Right? So this was a googly question, but it was a previous year question. The only thing was they had actually the correct answer. They had little modified it and presented it to you, but it was a previous year question. So there was nothing to be making mistake about it because we had read this so many times. Okay, then we come on to the next question. So this was a question. Phenylephrine was used in this patient and images shown below. So probable diagnosis is, well, it says phenylephrine. Now, this is the question I am real doubtful about. Because here it just says phenylephrine. If somebody could add to it what concentration was used, I would be more than happy. But if you still do not know, let's see. So when we see the picture, we are actually seeing here a nodule. So basically it was the DDs of the nodule near the limbus, which after phenylephrine had blanched. So but here the confusion for me right now is what was the correct answer. So it is obviously not nodular scleritis. We all know that. But deciding between flictin, conjunctivitis, and episcleritis is a question. When we talk of nodular flictin, we know it goes away with the use of 1% phenylephrine. Right? So that is how you differentiate between episcleritis and flictin, because flictin blanches with the use of 1% phenylephrine. And then the confusion arises between episcleritis and conjunctivitis. When we talk between these two, episcleritis and conjunctivitis, it is the concentration of 2.5% phenylephrine. Again, when you use 2% phenylephrine, conjunctivitis blanches. Right? But when we differentiate between episcleritis and scleritis, it is 10% phenylephrine which is used, which blanches episcleritis, because it has its effect on superficial episcleral plexus. So this is the question till now, which has actually put me to a little confusion whether what was the correct answer. But even if you do not remember the percentage, if you do not know what the percentage was, or if the question did not mention any percentage, still my most common answer, which is the most probable answer, would be nodular episcleritis. So we do come across such questions where we expect a little more to be told, but it is not there. Then you have to mark the most probable answer, right? So my answer, if I do not know the concentrations, then my most probable answer would be nodular episcleritis. It is matching up with the image here, and it is also matching up with what is the effect of the drug and the most common probability of the answer, right? So this would be nodular episcleritis. But then again, it was a simple question. It was a basic question. It was nothing out of the box. So till now, nothing out of the box except one canal of Pettit. That too, I told you, we reached till 2. So when we reach to 2 options, I don't call it out of the box. Okay, that is something which is in our reach and we have to attempt. Okay, so coming to the last one, it says vestibulo-ocular reflex. Again, there's a confusion here. Some say what is the ratio of eye movement to head movement. Some say what was the nerve involved. Well, I would answer both. The ratio of the eye movement to head movement, if we take, the gain here, it has to be 1. The gain is 1. So what is vestibulo-ocular reflex? It is the doll's eye movement or the doll's eye reflex. What do you do it? The most common is you move the head and the eyes move on the opposite side. So when the eyes move on the opposite side, what is the nerves involved? We all know 3, 6 and 8. We do not forget this. 3 ka double 6 plus 2 8. So 3, 6 and 8 is the number which we never forget when you talk of the doll's eye. यही तो हम याद रखते हैं. 3, 6 and 8. 8 goes to the semicircular canals and 3 and 6 are something which is supplying the muscles of the eye which are involved in the movement, horizontal movements, right? So 3, 6 and 8. If the question was the nerves involved, then the answer would be 3. If it had asked about the nerves involved. But if it says what is the ratio of the movement, then the answer would be 1. So I have given you both the answers, what had come. I am not sure what was exactly the question asked, whether it was a ratio of the movements or it was the nerves involved. Though it is again a previous year question. It is again a PYQ, right? It was again asked in the last year, which had asked about the nerves involved. So I fear it was again the question was again repeated exactly the same, asking about the nerves involved, but maybe it can happen, right? So this is all about INI-CET में. So if I now take an analysis of the 6 questions that were asked, so now we know it was 6 questions that were asked. So let's quickly revise and count what we have. So let's see. Quickly going through this image, the first question I said, this is canal of Pettit. Okay, I take that. That was one very difficult question. Agreed. All right, one very difficult question. The second that we have is this direct gonioscope, which is the direct question. So one is easy. Then we move on to sequence of staining. The sequence of staining is again something which is which I say it is a little bit of more of common sense, but okay, I will take it on this side saying difficult. So we have 2 difficult and 1 easy out of the 3 questions. Then we move on to this. This is a previous year question, goes into the easy one because this is a previous year question. Next, we go on to this question. Again, it was easy, it was basic. So 3 and 2, 3 easy and 2 difficult. Again, this was a previous year question. 4. So out of 6 questions, 4 questions were either easy or PYQs. And 2 questions were actually critical. All right. So, but that the balance still weighs on your side, right? So, this is what I always tell you, do not underestimate the power of PYQs. Do not forget, do not make the mistakes where the answers you already knew. And it is not about the questions. Please remember, previous year topics is what is to be done. We are not the ones who need to be spoon fed to a level that only the question repeat can be answered. We are on a very higher level. So any topic which has been asked in the past has to be on your tips. So now you all know the paper was actually balanced with tripping a little on the side that it had 2 difficult questions, but the other side is having 4 questions which were not to be made wrong. And these 2 questions also, one because of their error and one because of your common sense, could have been answered. So, anyways, whatever has happened, we have to learn the lesson out of it. Wishing you all the best. Good luck for the result. And still, I would say, knowledge means no boundaries, right? So keep working hard, but now you can take a break, right? Take a break, just relax yourself, just sit down and do whatever you want to do. We will take a little break. After this break, re energized, we will decide what is the next move. Till then, wish you happy relaxation and have a good time. Bye bye.